And I'll take the opportunity to ask the first question while you're thinking, and I think I'll direct this one to Oliver. So 2 drugs, Oliver, that we haven't particularly mentioned are denosumab and zoledronate. So now that we've got 3 drugs approved that improve survival and reduce the risk of SREs, abiraterone, enzalutamide and radium, what's the future for zoledronate and denosumab?
Great question, Chris, because it's actually the 3 drugs that are approved, but there are actually other agents as well. If you look at the enzalutamide data, the so-called skeletal-related events or symptomatic skeletal events, and there's a distinction there, is also improved. So we now are beginning to control the disease a bit better. And with that disease control, we have a variety of things that are improved, including these bone-related events that used to be uncontrollable, simply in part because we didn't have the therapies then as we do now. So I'll tell you that I'm a little more selective in the way that I use them. I'm making a distinction between those individuals that I think are at high risk and those who are at lower risk. And I'm also making a little bit of distinction about those individuals whose disease I think I can control. So it's not just a one-size-fits-all. I'm making clinical judgments, and then I have to admit that I don't know if I'm right or wrong. I do know that if we give more of some of these agents, that we have a little higher risk of toxicities and problems. So I always am in favor of using a dose of drug and a frequency of drug that is less likely to cause harm. So why don't I say that I'm using a risk-adjusted approach, and in some patients I use them, and in some I don't.
Okay. Do Rob or Howard want to comment on that or not?
No, excuse me. Our approach is very similar. There are some men who have significant bone loss when they come to us who start treatment, and those patients I will treat with a bone strengthening agent. It does depend on how well we can control the disease. So a patient essentially who has a normal bone density and has good disease control, I'm less concerned about, particularly if they have a long survival.
Actually, if I may, Chris, I think Howard made an important distinction between what I said, and he made reference to that bone mineral density, the osteopenia, osteoporosis, and I do think that that is something we do need to pay attention to, a little bit distinct from the skeletal-related events, but osteoporosis, osteopenia in these older men and long-term energy deprivation can be a very real issue.
Okay. So I've got a question I'd like to direct to Rob now about imaging. So Howard showed us a couple of very nice cases of patients who were progressing biochemically whilst on a hormone treatment and were having imaging every 3 months on a trial, and it was the imaging which really changed the treatment. So my question to you, Rob, is in routine clinical practice, rather than in a clinical trial, how often should we be imaging our patients and what modalities?
Yes, so I guess this is one of the big challenges we face, because Howard and Oliver and colleagues have actually completely redefined the way in which we monitor patients during clinical trials, moving away from purely PSA-based endpoints. That's a good thing. But the problem is of course, this monitoring is not really applicable to routine clinical practice, certainly not in the environment where I work. And so the idea of doing bone scans and CT scans every 8 weeks for the first 6 months and then every 3 weeks thereafter, it's not going to happen. And I guess it's particularly pertinent in the pre-chemotherapy niche, where you do by definition have another treatment to move on to if the patient is failing. And the other problem, as Howard showed us, is this real issue of tumor flare, and that is a real phenomenon. And so if you don't have a prior scan done within 13 weeks of starting therapy to compare your new scan with, it's almost impossible to know whether what you're seeing on your next scan is genuinely progression or a flare. I'll be honest, I haven't worked this out. My inclination now is I do tend to restage all of the patients before I start. And I'm tending to do it, particularly if there are future therapy options available to these patients, I'm tending to do another scan at or about the 3-month mark, and then after that, merely doing the scan if I am concerned that the patient is otherwise progressing.
What's happening in the States in routine clinical practice?
Well, I can speak for the 302 trial. it did in fact become a significant burden to have scans every 3 months, not every 3 weeks. But this is now a very ripe data set in order to start looking at how often these scans are informative. If a patient has a rising PSA and you're a little bit nervous, I think you can space out the intervals certainly when somebody has had a nice response to start with. There is an entity that we are seeing more of as we're using more of the androgen ablative strategies, specifically with the abiraterone acetate prednisone combination and enzalutamide. There is an entity where the patients acquire neuroendocrine-like characteristics. We see a visceral pattern that we had not seen before, and in some cases these will occur with absolutely no rise in PSA. So we do have to be vigilant for it. It's not that common, but it is becoming more frequent, particularly as we're using these hormonal agents longer and longer. But again, this boils down to showing when a scan is informative and literally asking a imaging biomarker question the same way we asked it in the trial. Can we establish progression as an endpoint that could be used for approvals instead of waiting for survival? So in the trial context, it had a very specific role. And if we can establish this in the PREVAIL trial, which was developed by Medivation and Astellas, also has a similar progression using the same working group trial metrics. And if you start to see consistent results, what was not presented was, one, how reproducible the interpretation of the scans was between essentially local sites and the, quote, central review. That brings cost of trials down significantly, and how strongly that associated with survival. And if we can, again, convince the regulatory agencies that these are important clinical benefits and they are significantly, you prolong progression significantly longer with your treatment, and we can get our drugs approved faster, that will have a huge impact on the field.
Okay, thank you. So a question for Oliver now on circulating tumour cell counts. So, I mean, Howard is the acknowledged authority on this and has presented some great data at this meeting about CTC counts predicting survival. So my question to you, Oliver, is this just something in the preserve of clinical trials and drug development, or is it ever going to be part of the average community physician's armoury?
You know, that's a great question. You know, you don't want to be sitting up here with Chris asking you questions. Say, I would have loved to have asked him that one first. Actually, and I'll go back for a moment to what Howard said, and I thought it was an important lesson because the CTCs did in fact play a vital role, but there was another parameter as well, and that was the LDH. And I don't want to forget about the older parameters that we've been dealing with for a long time, just because we have new therapies and new parameters available. So I'm actually not been convinced up to now about the utility of using CTCs on a routine basis. But you know what? I'm starting to get convinced that it's something I should track. And the reason that I'm becoming a bit more convinced is something called the Prentice Criteria, which Howard presented in his presentation on Saturday. And, you know, that's a very high threshold. That's not a low hurdle, that's a high hurdle to pass. And actually, it appeared to pass with the combination of the LDH and the CTCs, using a technology that I've been a little bit critical of because I've always been a little skeptical of this greater or less than 5. I just didn't quite understand how that could work. But, you know, I also have become relatively more agnostic in how I approach this disease because I started out with a lot of preconceptions that turned out not to be true. So now the data guides me a little bit more than my preconceptions, and right now the data has guided me in a pretty positive way.
Okay, thank you. So I've got one last question, which anybody can take, or all of you if you wish. So we've had lots of interesting CRPC data presented at this meeting. Is there anything that changes your practice, or anything that you think will change your practice from this meeting? And do you want some thinking time? Because if you want some thinking time, I'll give you one. So a poster today, Kim Chi in Vancouver, showing the food effect of abiraterone, fasted or fed. So we always thought it made a huge difference whether you had abiraterone on an empty stomach, fasted, or whether you were fed. Well, the data from Vancouver, no difference at all. So that's going to change the advice I give my patients. Okay. Any other suggestions?
Well, I'll go home with some questions that I want to try to answer, a couple of which will be the imaging question, because we hear from our patients, why do I need the radiation of a CAT scan every 3 months when I've responded for 3 years? One of the things we'll be looking at is whether CTCs can help us inform when it's time to do scans. There is some data from the breast cancer community which suggests that if the CTCs start to go up, that is a good time. We are asking that question in the 301 study because we have a large number of scans that were centrally sent to an imaging sponsor in California. So, the same way we developed the working group 2, working group 3 is under development, trying to address some of the newer questions. How do we redesign our trials? How do we account for our ability to start to see emerging resistant cells when everything else looks okay? So these are challenging questions, but we're very excited to be in a position to actually answer them.
I won't be using ipilimumab yet, and I'm not sure that I ever will, but I will be looking with great interest for the results of the pre-chemotherapy trial.
Okay. Oliver, you get the last word.
Well, I don't know about that, but on the other hand, there were a couple of things that I think maybe changed some of my preconceptions a little bit, so I'm going to have to go home and think about it more. And that IPI trial got a lot closer to being positive than I was initially presupposing. I looked at those initial waterfall plots and had concerns about the toxicity, and I said, well, it's unlikely that one's going to win. In truth, if you just shifted a few patients here or there, or perhaps had a little longer follow-up or a little bigger in, that trial could very well have been positive. And I was surprised about how positive it actually was. I didn't understand the toxicity, but I'm going to think more about IPI. I think that's a good point.
I know where they went wrong with that trial, actually, Oliver. What they did wrong was they included the US. If you forgot it, if you ignored the US patients, it was a positive trial.
That's a great note.
Well, we could also make some comments about the Europeans, but we're going to withhold those comments because I know where I am right now.
Right.
So
and you took a poll in the beginning in terms of the representation.
I saw where people were from.
So time's up. There's no time for Oliver to say that. So thank you very much for your attention this evening, and please join me in thanking our speakers. Thank you.
Thank you.